Hi, it's Jenny B, NSWC. Today I wanted to talk about gastric tubes because gastric tubes are part of in our NSWAC umbrella, and the management of them as well as insertion can be within the scope of practice. I've actually done this for many moons. When I was a community nurse, we would often do it for the pediatric patients. And to remember, Sick Kids will teach the parents of pediatric patients how to change these themselves so they don't have to be traveling back and forth to Toronto. They likely make a ton of trips anyways, so it is a skill that I was able to pick up. It's not something that everyone does have, but it actually is quite simple. It's actually probably simpler than a suprapubic catheter, or really just as easy because it's a straight in and out. We're not actually going into the urethra or in and around any caverns or corners. So a gastric tube, when they're placed, it's actually done in the operating room. It is done with a snare that goes down and helps to locate where the best placement would be on the stomach. It's usually up somewhere in the upper right quadrant, upper to mid. And that tube that they put in initially should actually stay in for approximately a year. The reason being is that it wants to allow for the stoma to mature, or so that the fundus actually attaches to the abdominal wall and that it does become a straight in and out stoma. So that being said, I wanted to show you a typical gastric tube that is put in then after that year's come out. It's usually something that I would do in clinic, that I'd pull that tube, and then we would switch over to a silicone tube. Now we are using the Kangaroo ENFit because ENFit has become the new standard of care. These are the purple lumens you'll actually see now on the ends of the tubes. It's to allow for a female connection versus the male connection with the purple syringes. You can actually only use the purple syringe, they're the only ones that'll fit in. They've done this because in past, when anyone was accessing potentially a central line, there could be a mix-up between somebody putting feed into a central line, which can cause a lot of havoc because it's not the right place for that solution to go in. So the ENFit are now pretty much a standard of care, and that's what you're going to see out and about. Now, they are silicone tubes, so because, again, they are quite flexible and movable, they can get damaged. So for the most part, we want to change these every 3 months, but if they do become damaged, sometimes it's quite often up at the hub here. I also like to note that these pieces then can come out. They actually do come out a little bit of tug, but this piece you can actually get separate ones that can be changed. So if there is a break or something in here, or there's any damage to any of the lumens, you can replace that. So again, I've had to do this with this piece on older tubes that perhaps hadn't been changed, or over the ENFit period when there's been about a 1.5 year transition for it, where we've had to switch because only the purple syringes were then available. We've switched over to these. So again, just to be aware that we can get these, they're sold separately and do fit into the gastric tube if they do need to be changed because of damage. The biggest thing between a gastric tube then and a catheter is really that we have this end piece on, which coming off, it would actually look like a catheter, but then is the slider. The slider is this round piece, it's got some holes in it, and you can see that when you place it, it's better on my black shirt, again, my black shirt. You can see there's some little divots so that this actually then anchors to the stomach wall. So this thing slides up and down the tube. It's the job for it to do is, its primary job is to allow it to anchor to the abdominal wall. The two biggest things that happen with a gastric tube, number one is some hypergranulated tissue around the opening, and as well as a bit of moisture. And those two things happen because this tube moves. So one of the big pieces with it is that we always want to try to anchor this to the stomach so that we're not having all that movement. And that's also part of why these sliders were developed, so that actually helps to anchor and prevents movement of this tube. Now, when inserting a gastric tube, for the most part, we don't check the balloons because it can actually cause damage to it. And we always want to use sterile water versus saline because the salt within the saline can cause tube erosion. So that's when you're looking at those big bottles, you want the ones with the blue cap, not the ones with the orange cap. And by placing these sterile water in here, we're going to inflate the balloon. I do have a preloaded syringe here just to show you what it does look like. And this being a 14 French, this one's actually going to only require about 5 mils. So this is what the balloon itself will end up looking like with 5 mils into it. So it doesn't offer a lot of space. It is difficult for it to actually pull out on its own, but it does happen. And sometimes it also does happen because the contents of the stomach are so erosive, they can actually erode the balloon and the tubes can fall out. And that's where I was really hoping to help clarify. So if you have had a gastric tube in that has been in over a year, a patient has been set up, in an interventional radiology department or with a surgeon to have them changed on a routine basis. Usually they're done every 3 months, but they're having issues with them falling out. The one piece, instead of having to send them to the emergency department, because often, they're not getting seen right away. They're not having anyone place them because, the surgeon might be in surgery because it's usually just one that's on call. One of the easiest things you can do is then whatever size tube, gastric tube you have placed in the patient, place a catheter in. Just a regular Foley catheter with the balloon size, whichever it matches. Usually anything up and over 18 has about 20 mils. What that's going to do, you don't essentially have to use it, but you're going to actually help prevent that stoma from closing. Why is that so important? Because we end up having to puncture the patient again, and sometimes they actually have to go back into the OR to have these placed, when if they just had a tube placed right back into the hole, we can then get the right size tube and put it back in once the surgeon or someone like myself is available to actually do that. Again, this happens at all times of the day, all times of the hour. That's the best thing to do, is to actually just place a catheter in. And if you're unsure, then by all means you can send them on. The catheter will again just prevent that stoma from closing over, because again that can be a huge issue. Now for pediatric patients, we actually use something called a Mickey, but I've actually used these in adults as well because they are so nice and small, and they're flush to the abdominal wall. So this is what a Mickey looks like. This is what it looks like prior to putting it in, but this is often all you end up seeing on the patient when they have one placed. This is also a smaller 14 tube, and again with the balloon with about 5 mils in, it inflates to about this. So this is for someone who's had a well-established stoma that, it might have been a couple of years even that they've had this in, that they're using, and it does allow for easier access for them. It prevents the tube from moving all the time, causing that hypergranulation, so that, they actually have a much better experience with it usually. It comes with a whole system that we do end up giving them their purple syringe to take home, and then they have 2 different types of locking mechanisms. The one that this tube will then lock into the Mickey. So when they open it, they actually go in and it locks, and they're able to then have an extension for their G-tube feed and hook to their kangaroo pump. So this is another option that patients do have. They usually are asked when they're in the IR which tube they would like. So I just wanted to make you aware that this is another option for patients, because they're not always aware. And again, if it's been under that 1 year, these are something that we're doing after that year, and that stoma has been well established. Hope that helps to clarify. My only other piece is that if you really do need a dressing for it, I always tend to use a gauze. I don't know where I put the one I have here. Cut like a drainage sponge, but I don't use just the average 4x4. I actually take a 2x2, and then I actually cut straight down here, and then I end up putting that in and around the tube so that it helps. Oh, here it is. That helps, here, my little pants. It helps to allow you to get it right around, and then it will actually stay in place. So when you're using this slider, you're able to get it underneath, and then you can actually slide it back closer to if we need to, and it just prevents any, if they do have a little bit of leakage from feed coming back, and or any lumps or bumps landing on them from the silicone slider itself. So hope that clarifies. If there's any comments or questions, please let me know. And in this case, this is the one wound that you don't want to have close. Have a great day.